really delighted to have our next speaker. And I never read through the full bios. I try to give my perspective of the person. I don't, we don't invite anybody here that we don't really care about. And we've been involved with Dr. Heather Zaluski since the suicide prevention conference about a decade ago. I met her through Glenn Lance, and it was just really an amazing experience trying to figure out what to bring to our state. And some of the things that came to that conference, we ended up putting in federal legislation that went around the world, or I'm sorry, around the United States, like the emergency room suicide prevention intervention by Barbara, but a woman from Colombia went all the way around the country, and it came out of that conference. And so what I was hoping for this presentation was to hear about child psychiatry. It's a really tough subject. It's a really hard subject. Where do child psychiatrists fit into our treatment system? If you're not confused about that, you're not paying attention. Like, it really is just that kind of hard of a thing. And and Dr. Zaluski is an amazing child psychiatrist. I'll flat out say I trust her with my family, with the people that I love. But she built an amazing practice after COVID. And you're going to see that with Dr. Bonsai tomorrow. I think there's some really cool clinicians that came out of COVID and came out of some of this saying, I want to do something different. I want to share my expertise in a different way. And I want to touch more people. And Dr. Heather Silly is an amazing example of that. And we're delighted to have you.
Thank you, Matt. Really appreciate that. So I will be talking, like Matt said, about child psychiatry and my practice and kind of how I'm trying to help more Montana families than I might have been able to if I had done like a traditional private practice. But I also wanted to talk about, I'm talking about this through the lens of first episode psychosis. So kind of the first part of the presentation will be about first episode psychosis. There's going to be some, technical language and some statistics and blah, blah, blah stuff. I just want to say, like, everything I talk about, I have a thorough reference page at the end. So all of the references are there if you feel like you want to do a deeper dive into any of that. And I will also be presenting a made-up case that we can talk through to kind of think about first episode psychosis and how it present and what some treatment options are. So that's kind of the approach I'll be taking today. So this is a little bit about me. I feel like it's only fair to share a little bit about me before we get started. So I'm not a native Montanan, but hopefully, we can work past that. I was born and raised in Michigan, graduated from Michigan State, trained at UNC, and I have lived in Helena since '07. So I've been here for, a decent chunk of time. Most of that time professionally, I was at Shodair Children's Hospital. I worked on all the different levels of care, inpatient, residential, helped start the outpatient program there. And then I was medical director there. You can see I took that position in December of 2019. So that was a real interesting time to take that position. And I was there until beginning of June in 2022. I was the medical director at RBHI. They do the school-based mental health screenings in the middle and high schools around Montana, or one of the people that do that for about a year. And then since last August, I've been in private practice at Big River Psychology in Helena. And then I also am partnering with Montana Pediatrics on a scalable mental health project. And then I'm also active with my professional organizations, ACAP and the Montana Association of Pediatric Psychiatry. So this is kind of what we're going to talk about today, or what I'll be talking about. It's kind of the who, what, why, and how of first episode psychosis, so that who it affects, what it looks like, as well as like what can impact outcomes. why people develop psychosis, as well as how to treat first episode psychosis, and then how child psychiatrists fit into the treatment. But before we get into all of that, I just wanted to take a minute to acknowledge that there are a lot of people in the audience with lived experience, as well as family members. And I know that this journey of experiencing psychosis or having a family member that experiences psychosis can be difficult. And I'll be talking from the perspective of a physician, but I just wanted to kind of put that out there and say that, people have had negative experiences or experiences that could have gone better. I know that does happen in our system, and I wish it didn't, but it's real. And so I just wanted to acknowledge that before we begin. Okay, so who is prone to develop first episode psychosis? So this usually happens either in the late teens or early 20s, so 15 to 25 years old is the peak time for developing first episode psychosis. So about 100,000 teens and young adults in the US will experience first episode psychosis every year, and about 3 out of 100 people will experience an episode of psychosis in their lifetime. So it's not a rare condition. It affects men and women equally, and it occurs across all cultures and socioeconomic groups. So it really doesn't discriminate in that way. This is kind of one of the more, la-di-da science topics, the role of genetics. And I think it's interesting. So I just want to say a couple things about it. Studies do suggest that a large portion of risk for schizophrenia is genetic, and that there's no single psychotic gene. It's a multi-gene kind of situation. And then while genetics play a major role, the environmental factors like stress, trauma, drug use can interact with genetics to trigger an onset of psychosis. And I think probably the most dramatic evidence for this is looking at twin studies. So for identical twins, if one twin has schizophrenia, the other twin has a 50% chance. So if you think like their genes are identical, but the risk is 50%, it's not 100%. So obviously environment also plays a role. And then in non-identical twins, it's a 1 in 8 chance. Then what? But what is psychosis and what is first episode psychosis? So the definition of psychosis loosely is just, a collection of symptoms that affect the mind, and then some loss of contact with reality. So during an episode of psychosis, people's thoughts and perceptions are disrupted, and they may have difficulty recognizing what is real and what is not. And then first episode psychosis is just also known as early psychosis or first break. It's an episode of mental illness that features psychosis, and there hasn't been a prior episode. So that's pretty straightforward. Some warning signs of early psychosis, like hearing, seeing, tasting, believing things that other people don't, being suspicious, very paranoid, uneasy, persistent, unusual thoughts or beliefs, either really unexpectedly strong emotions or just not showing any emotions at all, withdrawal from family and friends, sudden decline in self-care, and trouble thinking clearly or concentrating. There are a variety of psychiatric illnesses that include psychosis, so it's not just schizophrenia. There's also schizoaffective disorder, delusional disorder, depression with psychotic features, bipolar disorder with psychotic features. There are acute psychotic disorders, substance-induced psychotic disorders, and organic psychosis. Means there's something physical or medical that's happening that is causing the psychosis. And if we look at studies of outcomes, like what happens, so the majority of young adults that present with first episode psychosis will be diagnosed with schizophrenia. This is a 2-year follow-up study. So from the point of first episode psychosis, 2 years later, for the patients that were still experiencing psychosis, about a third had mood disorders, so either depression or bipolar disorder, and then the other 2/3 had schizophrenia spectrum disorders. So the good news is that the majority of these patients do recover. About 10 to 15% become treatment resistant, and there's also a group that has multiple relapse. So I think it's really important to talk about what treatment factors can improve outcomes. So having a multi-component treatment plan, having personalized psychosocial interventions, improvement of quality of healthcare, and that's kind of a big thing, but and then reducing the duration of psychosis. So it's very concerning that most of the patients that present with first episode psychosis have symptoms for over a year before they get treatment. And there is a lot of research and data that supports the idea that early treatment leads to better outcomes. So that statistic I find very concerning. So coordinated specialty care, or CSC, is considered the gold standard, the most effective treatment for first episode psychosis. And some of the key components are case management, family support and education, psychotherapy, medication management, supported education and employment, and peer support. So if we look at kind of demographic factors, like what patients are most likely to have positive outcomes, female gender, higher IQ, being employed, being in a relationship or living with family, and better functioning before experiencing psychosis are all demographic factors that are associated with a more positive outcome. In terms of risk factors for developing treatment-resistant schizophrenia, earlier age of onset or childhood onset schizophrenia, which is a rare disorder, but that's defined as diagnosis of schizophrenia before age 13. The longer duration of treatment of untreated psychosis, so kind of already touched on that earlier identification and treatment leads to better outcomes, a lack of insight, poor social functioning before developing psychosis, a lower educational level, and unfortunately, living in a rural environment is a risk factor. So, we're in Montana. So again, this is kind of one of those that's like, well, but what exactly do we do about that? But I think knowing that this knowledge is important, so knowing that people in Montana are at higher risk is important to know. And then why? What causes psychosis? So there is no one cause of psychosis. So it is often related to mental illness, but it also, if you experience severe sleep deprivation, you will start experiencing psychotic symptoms, some prescription medication, as well as some over-the-counter medication, and then abuse of drugs and alcohol can also lead to a psychotic state. So first episode psychosis does appear to be a result of complex combination of genetic risk, differences in brain development, exposures to stress or trauma, and then drugs of abuse, especially cannabis, can contribute to first episode psychosis. And I did want to do a little bit of a deeper dive into what exactly the evidence supports in regards to first episode psychosis and cannabis, because there's it's kind of a hot topic in child psychiatry, and I think it's very relevant. And there was what's called an umbrella review, so like a review of all of the reviews of the reviews that was published this year. They asked like over 50 research questions and really looked very comprehensively at like, okay, what can we say is true? What do we not have enough evidence for? What can we know is not true? This is what they found. There was sufficient evidence to like say yes. So if you use cannabis, and and you're in the healthy population, you can have psychotic-like experiences. It is associated with the development of psychosis. It contributes to worse symptoms in people who have schizotypal personality disorder. There's a higher risk of relapse and earlier age of onset, which we also know is more likely to lead to treatment resistance, because that's not a good thing. And then there are some connections that were found. So one was that more frequent cannabis use increased the risk of psychosis, more potent forms of cannabis increase the risk of psychosis. And then also people who are using cannabis, if those people have a history of childhood trauma, they're more likely to develop psychosis. So there's also a connection there between childhood trauma and psychosis. Then how do we treat first episode psychosis? What is recommended for treatment? So treatment goals, I think it's really important to say that the goal of treatment is remission, not just symptom improvement. So we really want first episode patients to experience full remission. And the good news is that in patients that are treated with hopefully a multidisciplinary treatment model that also are started on antipsychotics, 80% will respond and 80% will reach remission. So this is a good, these are really high numbers in psychiatry for response to medication. So we do in psychiatry really consider first episode psychosis to be a condition that responds well to medication treatment. So when would we expect a response? There should be symptom improvement after 2 to 4 weeks of treatment, but it can take several months to reach remission. So bad news is that relapse can be devastating, and in patients that discontinue medication after an episode of first episode psychosis, and I should say, like not working like with their doctor, but like discontinue the medications on their own, about 80% do experience a relapse. So for this reason, the guidelines recommend staying on medication for between 1 and 3 years after achieving remission, and then working really closely with your doctor or nurse practitioner or whoever you're working with to take her off the medication gradually. So how do we know if a patient presents or a family member or a loved one or a friend seems to be experiencing first episode of psychosis? How do we know if it's an emergency? And about 70% of patients who are experiencing first episode psychosis are in a state of psychiatric emergency. So it's a very serious condition, and oftentimes going to the emergency room is the appropriate step. Not always, but often. So some signs that it's an emergency would be command, auditory hallucination, so voices telling the person to harm themselves or to harm others, risk of imminent harm like suicidal thoughts or delusional thinking or paranoia that could lead to harming themselves or others, as well as the inability to care for themselves to the extent that basic needs are not being met. So they're not eating, they're not drinking enough fluids, they're not sleeping. Really kind of extreme inability to care for themselves. And then if you go to the emergency department, I think, again, as people with lived experience with family members, it's really important to know what should happen there. So they, should be screened for common medical or substance-related causes of psychosis. So drug abuse, delirium is a medical condition where for any number of reasons the person is in a state of altered reality, and they tend to kind of wax and wane in and out of that state. Overdose, a lot of drugs, and one that is maybe not commonly known, but antihistamines like Benadryl overdose can lead to a very extreme psychotic state. So Benadryl overdose can be very, very dangerous, as well as medication-induced psychosis. So there are a lot of things that the ER should be screening for. We should make sure the patient's medically stable. There should be a mental health evaluation that's done. And then, the purpose of going to the ER really is to figure out the next step. And so because, most patients that present there are often in a state of psychiatric emergency, the most common next step would be referral to inpatient care. There's a lot of guidelines, and I did include a reference to this a bit in my presentation about what a workup for first episode psychosis should look like. So there's, kind of the standard stuff, right? Vital signs, neurophysical, neurological examination, laboratory studies, and those should include screening for infectious causes, including sexually transmitted diseases like HIV and syphilis, metabolic causes, liver and thyroid problems. Neuroimaging has been kind of considered controversial, but a study came out in 2023 that supported neuroimaging in first episode psychosis. So that would be either CT scan or brain MRI, because approximately 6% of patients with first episode psychosis had an abnormality that required a change in clinical management. That's actually a pretty high number, and it's higher than what had been found in previous studies. So at this point, brain imaging is considered part of the at the first episode psychosis workup. And again, this is kind of really, getting a little bit in the weeds, but there are some additional tests that could be ordered. Copper or ceruloplasmin levels to screen for Wilson's disease, which is a rare genetic condition of copper metabolism. Anti-NMDA receptor antibodies, autoimmune encephalitis is a condition that's kind of come into our awareness as doctors, as psychiatrists within the past 5 to 10 years. Mostly affects young women, and it does present with a variety of neuropsychiatric changes. Genetic testing, this is not going to diagnose psychosis by any means, and it's really not that clinically useful currently, but it's an emerging field. And then in EEG, if there's any concern for seizures, because seizures can present looking very much like psychosis, especially temporal lobe seizures. So if the person that is experiencing first episode psychosis gets admitted to a hospital, I also feel like it's important to know kind of what should happen in the hospital. And, as, there's friends or family members to know what you should be advocating for. The average stay in an inpatient unit is about 7 days. And so realistically, it's not realistic to expect that the symptoms will completely go away while the patient's in the hospital. So just, it's important to have realistic expectations. Again, the inpatient team should conduct a comprehensive evaluation, including thorough workup for possible medical causes. It's likely that medication will be initiated, and then the patient is monitored to make sure that they're tolerating the medication before discharge. So then what should we expect at discharge? The patient should be stable, which generally means they're not in any, immediate danger of harming themselves or others. They're doing okay on medication, and that, aftercare has been established and the patient is agreeing to it. The inpatient team should set up that aftercare, and standard care is that there will be a follow-up appointment discharge. And again, I have this guideline in the references if you really want to get into more detail about this, but there was just last month an updated guideline for antipsychotic selection in first episode psychosis. And they really make a pretty clear delineation between patients with violence and patients without violence. That's kind of how the little flow chart bridges. And so in patients with violence, olanzapine, or Zyprexa is the brand name for that, is the first choice agent. And then in patients without violence, there are several options, still includes olanzapine, but also aripiprazole, risperidone, and I was surprised to see perfenazine, but it is also in the recommendation. So if inpatient care is not the path that the first episode of psychosis takes, then what, right? So if there's no emergency, if the patient's not in a situation where they have to be admitted to a hospital, so maybe they go to the ER and the ER says, you don't need to be in the hospital, or maybe, they don't need to go to the ER at all. That's fine as long as the person has rapid access to psychiatric care, okay? And so this is kind of where we're gonna shift into talking about child psychiatry and kind of different programs and options, because if anybody's ever tried to just call a psychiatrist, call a child psychiatrist that's in private practice and make an appointment, you're gonna be told there's a wait list, it could be 6 months, it could be a year, or you could just be told taking new patients. Rapid access to psychiatric care is difficult to achieve, and these are not people that can wait 6 months or a year to be seen. That is just not appropriate. So what are some other options, right? So this is a program. Honestly, to be completely honest with you guys, I didn't even know about this program until I started doing research for this presentation. I don't know if it's because it's based in Billings or I just haven't looked into it before, but apparently there is a program that's based in Billings that uses a coordinated specialty care model. So program coordinator, psychiatrist, therapist, case manager, called Epic Montana. So, and if you go to that website, there's like phone numbers and how to contact them. And it's for adolescents down to age 16 and young adults. Integrated behavioral health, which is kind of the model that of the program that I'm working with Montana Pediatrics. So this is a model where primary care practitioners, so pediatricians, family practice doc, have access to consult with psychiatrists. And so this allows patients to be seen by their primary care doctor, which, it's a lot easier to get an appointment with your primary care doctor than it is to get an appointment with a psychiatrist. And also people are often more comfortable being seen by their, the doctor they've been seeing for years, than seeing somebody new. So that's a comforting thing. And, so access and just comfort for patients. And then primary care doctors, because they're consulting with the psychiatrist, they can more confidently treat complicated patients, including patients that are presenting with psychosis. And then consultative psychiatric care is another model, and that's what I do in my private practice. So I get referrals from primary care docs. When I say docs, I also mean like advanced practice practitioners, like nurse practitioners, etc. So they refer patients to me when they have a complicated patient, or they feel like they, are outside of their comfort zone with a psychiatric concern. I evaluate the patient, and this is like what the consultative psychiatric care model is. I'll make diagnoses. If medication is part of the treatment plan, we'll start medication, and then I follow the patient until they are stable, at which point, either I refer the patient back to their primary care doctor, or we work together to find a longer term psychiatric clinician. So this is where, I might follow them for 6 months while they're waiting to see, for example, Dr. Lintz or another psychiatrist that is harder to get into quickly. And then I do want to talk a little bit about like child psychiatry as opposed to, I think, in general, they're referred to as adult psychiatrists, although that's not technically true. People who do a 4-year residency in psychiatry are trained to treat people across the lifespan. So they're generalists, they're general psychiatrists, but commonly called adult psychiatrists, and a lot of them, frankly, are not comfortable treating children. So we'll just say adult psychiatrists. So why are child psychiatrists, in my opinion, better trained to treat first episode psychosis? So we learn a lot about brain development, and that's something we're always thinking about when we're evaluating a patient. And really, brain development does continue into the early to mid 20s, and it's really thought that this is kind of maybe why psychotic disorders tend to emerge at this time, because there's like a pruning process that happens in the brain where the brain's like getting rid of neurons it doesn't need, and a lot of the neuroimaging suggests that like that process is different in people who develop schizophrenia. And this is and again, this is when most of first episode psychosis present. So that's something that I think we think about a lot more than general psychiatrists, as well as we include the family. That is like standard of care. We don't evaluate kids without incorporating their families, and that is a key part of evidence-based treatment. And then we also routinely assess for childhood trauma, which is maybe something that adult or general psychiatrists aren't focused on as much. And this is a known risk factor for development of psychosis. And again, our training is focused on child and adolescent patients, and roughly 15% of cases of schizophrenia do start before the age of 18, and then roughly 50% or more start by 24, 25. But again, access, right? Like, okay, great, you convinced me, like that's wonderful to have a child psychiatrist treat patients with first episode psychosis. So what does that look like in real life? So really, first of all, any patient under the age of 18 should be admitted to a dedicated child and adolescent unit. They should not be on a unit with adults. That's inappropriate. And so if you are advocating for a family member, you should definitely insist on being admitted to a dedicated child unit. And the treatment team should be led by a child psychiatrist. That is the standard of care that's endorsed by ACAP. we are in the process of publishing an updated practice parameter that clearly says that. So this is something else important to know. And then at the point of discharge, you really, you or your, it's appropriate to that the person be referred to a child psychiatrist for active care. So that's inpatient, and then outpatient, some options for access that again is easier or faster or more readily available than just a referral to somebody in private practice would be integrated behavioral health, like we do at Montana Pediatrics. The Children's Clinic of Billings also does a version of integrated behavioral health. There may be other practices out there that I just don't know about. That is one option. And then again, this Epic Montana does treat teens down to the age of 16, and they are roughly following the CSC model, as far as I can tell. And then again, in my practice, so when I started my practice a year ago, I really wanted to be able to help more kids than I would be able to if I just, on my shingle and took however many patients, and then, I was full with a wait list. I also feel like as a child psychiatrist, I really should be working to the top of my training. So patients that are pretty straightforward, straightforward ADHD or, depression, anxiety, that they can be managed by their primary care doctor or by nurse practitioners very competently. They don't really need to see me. So I was trying to think of like how I could see more patients and try to see the patients that had more complex needs. And so this is kind of what I came up with. It's unfortunately not really that widely available, or it's not really like a model of care that a lot of child psychiatrists have adopted. But I felt like it was important, and that's why I have been doing that, and it's been going very well. I would say Montana pediatricians and practice docs are very open to this model, probably more open than in some other parts of the country. Partly because, child psychiatrists are so rare in Montana. There's only about 25 of us in total in the whole state, and most of them are clustered and in inpatient units or in private practice. So they're just, prior to, like me opening my practice and developing this model, a lot of the pediatricians and other primary care docs just didn't have any options because the people who are in private practice are all full, so they appreciate, having access, and they've been great about taking patients back when we're done working together. So a year in, I can say this model is working well. So with that, I thought I did where I went to medical school in Michigan State, we did problem-based learning. And so this is kind of how I learned best. And I thought, putting this information, which, I know I did kind of put a lot of information out there into, a case, again, this is a made-up case, would be a good way to kind of relate or to, kind of bring home some of the points. So Sarah is a 17-year-old high school senior. She's in Belgrade, Montana. Her mom, Beth, has noticed some concerning changes in Sarah lately. The past few months, Sarah's been more withdrawn and isolated. They try to have family dinner, and Sarah's been refusing. She's been spending most of her time in her room, doesn't like parents to come in. She started not showering very regularly. She rarely does her hair, makeup, and this is a big change for Sarah. In addition, she's typically been a pretty good student, but this fall, her grades are slipping, and she's a talented soccer player. She's been playing since she was in elementary school, but been skipping practice recently, and just this past weekend, she told her parents she wants to quit the team. So mom, Beth, is concerned about these changes and feels like, she doesn't know who to turn to, so she takes Sarah to see her pediatrician, Dr. Smith. And Dr. Smith talks to Beth and Sarah, and then pulls Sarah aside to talk to her one-on-one, and Sarah does admit to smoking weed. regularly since last summer. She also tells Dr. Smith that she sometimes hears voices. They usually happen at night, often after she smokes, and she can't make out the voices. They can just mumble. And then Sarah really begs Dr. Smith not to tell her mom about the fact that she's been smoking weed. So at this point, so here's some questions, the opportunity for audience participation. So we like to do interactive presentations. So who in the audience thinks that Sarah is showing signs of first episode psychosis? Yeah, yeah. So what are some of the signs that Sarah is showing? Oh, is Megan thinking that? The people, what about the case would make you think that Sarah might be experiencing first episode psychosis at this time? Withdrawal, yep, good one. Isolation, another really good one. Poor hygiene, grooming, absolutely. Paranoia.
Use of marijuana.
Yeah, the marijuana use is concerning, isn't it? Yeah.
You can see that.
What's that?
You can see that.
Yeah, like she's hearing voices, right? She's hearing voices. She can't really make out what they're saying, but she is hearing voices, which is new.
I have a question.
Yeah.
Does it ever present earlier than 15 or 16 that you know of?
Yes, so there is childhood onset schizophrenia that's defined as before age 13. It is rare, it is a rare disorder, but it does happen. Okay, so what are some other mental health diagnoses that Dr. Smith should consider? Maybe she shouldn't just jump to first episode. Like what else might she think about? Depression, yeah, or bipolar, right? A mood disorder, right? I mean, a lot of these symptoms are very suggestive of a major depressive episode. So that's definitely something that Dr. Smith should consider. And then what are some
Yeah,
questions?
We have,
Oh, sorry, go ahead. Yeah.
sorry.
Does it also cause moods like anger, like you go from one mood to the next?
Yeah, that can be a sign of first episode psychosis, rapidly changing moods or sudden anger outbursts, things that are really, I mean, things that are different from how the person typically behaves, right? Those are some of the warning signs. So what are some questions that Dr. Smith should ask to make sure that Sarah's safe, to make sure that it's okay to send her home today? Is she suicidal? Excellent. Always ask about suicidal thoughts.
Asking those hard questions of if she's being abused at home, if she feels safe with her parents or friends.
Exactly. Yeah, definitely you want to screen for abuse. I mean, not only because it's a known risk factor for developing psychosis, but also because this is something important that pediatricians and, all clinicians that work with children should definitely have on their radar. So any other questions?
If she's looking forward to coming back for her next visit,
Yeah, that's a
she's
really
part of
good
the
one.
treatment.
Yeah, and that's actually that kind of touches on an area of emerging research, which is that this idea of hopelessness is a very, we know that hopelessness is a very strong risk factor for suicide, kind of almost independent of, depression or other symptoms. Just feeling hopeless is a very strong risk factor for suicide. So that question of kind of future thinking or looking forward to things. Yeah.
The question about the person not being aware that that they have something or that have psychosis or it being a different world kind of.
Right.
And hard to come back to the world with other people.
Yeah, so we know that poor insight is a risk factor for treatment-resistant psychosis, and making sure that Sarah is kind of based in reality and understands that these experiences she's having are unusual and not normal.
Is the question also what's going on at school?
Well, I believe me, I always ask about school. School is super important, but I don't know that that is something that would determine if it's safe for Sarah to go home. But again, the school environment, what's happening at school. And then, we do know that her performance at school is slipping, and that's very concerning.
Are you ready?
Yeah.
What is the best way to deal with defensiveness of parents or
Mhm.
children who are in denial of the fact that their kid or that the kid itself has a mental illness?
Mhm.
And dealing like with the embarrassment or the stigma
Yeah.
of it, or maybe possibly being bullied for that reason
Mhm.
and so on.
Yeah, you do ask a hard question, and this is something I deal with a lot. So a lot of it is normalizing the situation, particularly in terms of like depression or those sort or anxiety. Just talking about like how common it is that many people have these experiences. The person is definitely not alone in their experiences. And then as far as parental defensiveness, I often will, just kind of try to bring it back to like, well, I know you love your child. And, I mean, what parents would going to say, no, I don't love my child, right? Like parents love their kids, even if they're maybe not going about parenting in the most effective way, they do love their children. They want the best for them. They want them to be happy and healthy and to thrive. Like, and usually, so we can usually join. I mean, the goal is to like join with the parent. As one of my mentors used to say, parents may be part of the problem, but they have to be part of the solution. So you have to figure out a way to join in them. And usually that you want what's best for your child. You want your child to be happy. You love your child. Like those are usually areas where we can join. And then we can look at, okay, so, we know that you love Sarah and that you want Sarah to be happy. And it doesn't seem like Sarah's very happy right now. So what can we do to help Sarah? And that most of the time is effective. Yeah.
I actually have a question.
Yeah.
So I've been thinking since you were talking about like struggles
Mhm.
and children and adults suffer with mental health.
Mhm.
Well, I have to say that growing up with parents who were very, very sick and mentally ill, it was really hard for me as a teenager to go through what I was going through and try to figure out which diagnosis I actually had from my mom or my dad, because they both had separate kinds.
Yeah.
So how in the world was I supposed to be okay with myself and learn how to deal with my coping skills, my ways of living, when my parents are not doing well either?
Yeah, and I am sorry that you had to experience that, and I don't have an easy answer for you. I hope that you were able to connect with like a therapist who could support you in that journey. I think in a situation like that, unfortunately, probably turning to your own parents for support wasn't going to be super successful. And in those situations, having other adults that you can turn to as well as peers, if there are peers that are supportive, can be really a lifeline for making it through those difficult years and into adulthood when you can kind of separate from parents and establish your own life. So I do hope that you had some people in your life that were able to help you do that. Yeah, we'll take this and then we'll kind of move on. I do have like just a little bit more to talk about. So
Thyroid and seizures,
Mhm.
and I struggle with both.
Oh.
I was wondering if you could say more.
Yeah, for sure. So thyroid disorders, either too low of thyroid or too high of thyroid, can present as looking very much like mental illness. So low thyroid can look very much like depression, because you're very slowed down, you're sluggish, you sleep a lot, you just don't have any energy. So that can look a lot like depression. And then on the other end, hyperthyroid or too much thyroid can lead you into what looks like a manic episode. So anybody who presents with a mood disorder really should be screened for thyroid problems. And then seizures, there are many different kinds of seizures, and kind of the classic seizures we think of, grand mal seizures, or tonic-clonic seizures where you fall on the ground and shake. That doesn't really look like a mental illness. But there are other types of seizures, specifically like temporal lobe seizures, that can present very oddly and can look a lot like an episode of mental illness. So that's why that can be an important thing to rule out. So then just briefly running through the rest of these questions. So in terms of what Dr. Smith could tell Sarah about her cannabis abuse or cannabis use, she could tell her that the fact that she's already experiencing psychotic symptoms means that really she should stop using cannabis because cannabis can cause more psychotic symptoms and make things a lot more difficult for Sarah. Does Dr. Smith need to tell Sarah's mom? That's a really hard one. As a child psychiatrist, tend to err on the side of respecting privacy and not disclosing things that my patients don't want me to disclose unless it is an absolute emergency. So I would say if Sarah is able to like verbally commit to me that she's going to stop using, I would then kind of negotiate with Sarah, like, okay, we have this agreement, we're gonna follow up really closely, and you're gonna, and Dr. Smith, we're gonna make sure that you are stopping smoking, then we don't need to tell mom, but if this continues or it escalates, then we're gonna get to that point. So that's how I would handle it. So warning signs, any worsening of the poor hygiene, the withdrawal, anytime that if Sarah were to start talking about voices, not just mumbling, but like telling her to do things, particularly telling her to do things to hurt herself or to hurt others, paranoia about people being out to get her, needing to, seek revenge against people, those would all be warning signs that things have escalated to the point where it's a crisis. And then in terms of the best next step in treatment, I believe that a patient like Sarah should be seen by a child psychiatrist and as quickly as possible. And so like I would hope that Dr. Smith would reach out to somebody with me who could see Sarah relatively quickly. My wait time for a new patient appointment is roughly a month right now, and my goal is to always keep it at a month or less because I feel like kids need to be seen when they need to be seen. So that would be one option. Sarah's 17, so maybe the Epic Montana program would be an option. And then if Dr. Smith is like at the Children's Clinic of Billings, for example, I know they have a psychiatric nurse practitioner embedded in their practice, and Dr. Smith could refer directly to her for an evaluation. So take home points, just to wrap up, and then I do have a few more minutes for questions. So first episode psychosis most commonly happens during the teen to young adult years. Early identification is very important. It can change the whole course of the illness. Treatment should be multidisciplinary, right? It's not just giving a person a pill by any means. And CSC offers the best treatment of FEP if you can access it. I will also say, as part of my research for this presentation, I just kind of did like a Google search for like treatment centers, or, like evidence-based treatment centers for FEP, like who's doing CSC nationally. And at least one of the searches, the closest program that I could find is in Portland, Oregon, which is not easy for people.
What does the say stand for?
That is coordinated specialty care. So that's kind of like the multidisciplinary treatment. Yeah, thank you. Sorry to use acronyms. Cause of FEP is complex. There's no one thing. Genetics do play a role in many cases. So that's why asking about family history, which is something else that child psychiatrists are very trained to do, and we focus on a lot, is the genetic component of family history. And that cannabis can trigger an episode of FEP. So other take-home points, it often presents as a psychiatric emergency. There should be a thorough workup that includes physical exam, neurological exam, labs, imaging at a minimum. Many patients will be admitted to an inpatient unit. But FEP, as long as it's not an emergency, can be treated in the outpatient setting, but rapid access to psychiatric care is key in those cases. And it is my belief that child psychiatrists are uniquely trained to address FEP. So that is the end of my presentation. Thank you. I have my contact information. I believe all of these slides will be available, right?
Yeah, we'll put them on our website.
Okay. And then these are the references that I mentioned. And then I do have some book recommendations I really like to read, and I feel like learning through stories is how humans learn best. I have a few of the books here with me, but I'll just mention real quickly. The Brain on Fire is a first-person account by a journalist of a patient who had anti-NMDA receptor, so autoimmune encephalitis, and it was misdiagnosed and missed for a long time. These are the Center Cannot Hold is a first person account of schizophrenia. The Collected Schizophrenias are some short stories. He by Bill Jameson is a very famous author and professor. I believe she's going to be speaking at the NAMI conference this year. Or no, or not NAMI, sorry, the Montana Psychiatry.
She might be.
Okay, anyway.
I don't look at that agenda until we finish this.
Okay, sure. All right, I'm looking for that. So this is, she has bipolar disorder. She has experienced psychosis. She's written a number of books. So this is a memoir. And then I Know This Much Is True by Wally Lamb is the story of a man whose twin brother had schizophrenia. And is also a pretty well-known book, and I've read it personally, and I think is well written. So that's it. Thank you.
Some workplaces you know to be telehealth.
I do, right. So my practice is based in Helena, but I do offer telehealth, so I can see kids from all over the state that in that way. So they don't need to travel to Helena to see me.
Good.
So yeah. Mhm.
Thank you. And before we get to this questions, I do want to say that the behavioral health division has a real focus on first episode psychosis. And with NAMI, we see if people get early good care, their lives are better faster. Like recovery is totally possible, but early good care really works. So we're really grateful for this division for the focus. So we'll go into questions now.
Yeah, and I will stay like until about noon, and then I'll be around later this afternoon as well. So
I just want to make a quick comment on something. A couple of weeks ago, there was something in town called "It's Not Your Grandparents' Marijuana Anymore."
right.
And it was a really good
Yeah.
presentation about how the
Yeah.
state of the THC and marijuana has changed so much. In the
Right.
70s, it was 2%, and now they got it genetically modified up to 34%,
Right.
edibles even higher. So
Yeah.
I think that's a really important thing to realize. I know a young adult doesn't really want to hear that sometimes,
Right.
because they're bulletproof.
Right.
But I think something, if you're observing someone with a lot of marijuana use, it can be a big factor.
That's an excellent point. And again, like those more potent forms, like you're saying, like the edibles or the waxes, the dab, the vaporized, those can be even higher. And that is definitely more strongly linked with psychosis. So smoking your grandparents' marijuana might have been okay, but the stuff that's out today is dangerous.
Hi. My question has to do with your note on there's 25 psychiatrists in the entire state.
Child psychiatrist.
Child psychiatrists.
Yeah.
My question is, do you organize within this network? Is there an informal formal group? And as these pioneers, if you will, in the state, how are you seeing an expansion or potential to get it deeper into the rural areas?
Yeah, thank you. So yeah, the Montana chapter of child and adolescent psychiatry or pediatric psychiatry is our state level group. So ACAP, the American Academy of Child and Adolescent Psychiatry, is the national level, and then at the state level we have the Montana chapter. So we meet twice a year, and also we have a statewide Montana Psychiatry Conference. It's for all doctors or clinicians who are in psychiatry that takes place every November. So that's a really great place for us to get together and network. And then as far as workforce challenges, I wish there was a great answer. It's great that we didn't. I've been, like I said, in Montana since 2007. We did not even have a residency program in Montana for most of the time I've been here. We now do have a residency program in Billings. I believe it only has 3 slots. and there's no child fellowship. So like for me, to be a child psychiatrist, in addition to doing 3 to 4 years of general psychiatry, you have to do a 2-year child fellowship. Right now, there is no fellowship program in Montana, and people tend to stay where they train. So one of my like dreams would be that we would have a child fellowship in Montana, and I feel like that would help to, recruit and retain child psychiatrists to our state. So I would be super excited at some point in my career to be a part of that. We are seeing a lot of nurse practitioners graduate and work in Montana. I personally really support this. I feel like it does improve access. And I feel like it's important for there to be a team-based approach, and particularly for these more complex cases, that a child psychiatrist is involved in the child's care. So that's what I helped bring nurse practitioners to Shodair when I was there, and I supervised them, and we had, really great people there. And I believe in that model, but I do think that it's important that, again, not for straightforward, anxiety, depression, ADHD, but more complicated cases, that there's a child psychiatrist involved, just because we do have so much more training. I hope that helps.
Question over there.
I'd like to know what the solution to youth in the Department of Corrections.
Yes, thank you. I strongly believe that psychiatry should be more integrated into our correctional system. We know, I can't spout the statistic off the top of my head, but we know that many people who are in the correctional system have mental illness and substance use disorders that are not adequately or appropriately treated while they are in that system. And that is an area that needs to be reformed. I mean, I can speak for myself that I had a patient that was in JDC here in Great Falls long-term, and I did continue to see that patient via telehealth during his stay there. So it is possible, like they did set up Zoom and we were able to meet. So it is possible, but I kept seeing him much longer than I normally would see a patient, because I just didn't know that anybody else would do that, frankly. So that is an area where there needs to be a lot of reform.
I just wonder if cannabis is unique in its triggering effects, or if there are other substances that do the same thing.
Yeah, thank you for that question. I mean, I think hallucinogens the whole point of taking a hallucinogen is to hallucinate, right? So there's a direct psychosis inducing effect from hallucinogens, right? Acid, etc. So, and that can then trigger psychosis that lingers. Okay, so there is a connection there, but honestly, cannabis is so much more widely used, and it does really appear that there is a kind of unique impact of cannabis on the brain, as opposed to like alcohol or other substances that are not hallucinogens, right? So of the non-hallucinogen substances that a person could use or abuse, cannabis does seem to be unique in its tendency to trigger psychosis or make psychosis worse.
As a fraternal twin, I was wondering if you could say more about that.
I am not a geneticist, so I don't know that I can. I'll only just say that the risk is higher in fraternal twins, right? 1 in 8 is obviously a lot higher than the risk in the general population, but it's not as high as in identical twins, which, those twin studies are really important because they can help us to tease out what's the role of genetics and what's the role of environment. Even though fraternal twins don't share genetics, any more than any other sibling, they do share, the same environment from, pregnancy onward. So I think that 1 in 8 risk speaks a lot to the environmental factors involved.
I was just curious. So my mom had a couple different diagnoses and my dad had 2. But I only ended up with like just half of my dad's and most of my mom's. So does that mean because of their mental issues or maybe because of their genes? Maybe my mom's was stronger or maybe my dad's was stronger, like how can you explain to me that it wasn't just the genes, it was their mental issues or something that was holding that grasp that gave me some of hers and some of his. It's just kind of confusing to me.
Yeah, that is a confusing area. And, I'd say obviously, we are all, like when we're born, half of our genetic makeup comes from our dad and comes from our mom. So we are a mix, right? And then, yeah, some genes are stronger, like present more strongly than others. There's also a lot of interesting emerging research that I don't really understand, but about epigenetics, which is like how genes and the environment interact and like what happens to you environmentally. In particular, I think this is where childhood trauma probably plays a strong role. Literally impacts gene expression. So it doesn't change the genes you have, but it can change like if those genes are turned on or turned off or these sorts of things. So I think that's where genetics and environment really interplay on like a cellular level. And then obviously, your upbringing, right, and being parented by your mom and dad who struggled with mental illness, that has a significant role as well. So I can't like draw like a pie chart to tell you, but I would say it's a combination of those factors.
Thank you. And this is the last question for Dr. Zaluski, but she will be available at the front.
Yeah, just last question here. I was wondering if psychosis or schizoaffective disorder could be induced by a brain injury at birth. Is that possible?
So traumatic brain injury at birth can have a lot of different effects on a person throughout their lifespan. I don't know that there's a lot of really direct evidence that would cause psychosis, but obviously, it having a traumatic brain injury at any age changes your brain, and so there could be a link there. Okay, thank you, everyone, and yeah, I'll be up here.